Hello, my name's Amir. Today we're going to talk about erectile dysfunction. Now the first thing to say is that it can be embarrassing for patients to talk about something so personal and so intimate with you, the GP. So the most important point of the toolkit today is we've got to be sensitive to this, we've got to be empathetic, and we have to discuss these issues in a very matter-of-fact way, because as soon as we're embarrassed, then we project onto the patient and they're very unlikely to open up to you. And you have to remember that these patients may have suffered with this for many weeks and months, which results in breakdown of relationships with their partners, and then it becomes a vicious cycle and a self-fulfilling prophecy. So it's something that we need to take very seriously and need to approach extremely sensitively. The first thing to do is really decide, is the cause of erectile dysfunction, is it organic, i.e. physical, or non-organic, psychogenic? Now, a few basic questions can tell us, what the likely cause is. The first question is, do they wake up with an erection in the morning? If the answer is yes, then it's extremely unlikely that we're looking at an organic cause. There are some also other questions to ask, and again, should be asked in a very matter-of-fact way, like, is the patient able to initiate or maintain an erection at other times in the day, or are they able to masturbate and achieve ejaculation at other times in the day, away from the intimacy of their partner? And again, if the answer is yes, then you're not really looking at an organic cause. Now, assuming that they're not able to do any of these things, then we're thinking of organic causes. I'm going to give you a list of organic causes that will be really important to know. It's by no means an exhaustive list, but it's certainly ones that we need to be asking to try and look for organic causes. The first thing is, what have we done to the patient in terms of the medication that we've prescribed? Because many common meds that we give can certainly cause erectile dysfunction. And the most common ones would include things like antihypertensives, like ACE inhibitors, calcium channel blockers, diuretics. These can all cause erectile dysfunction. Other things like antidepressants, SSRIs, tricyclic antidepressants, non-steroidals, antihistamines. So bear that in mind. Endocrine causes, commonly diabetes. We know very well that diabetes, one of the complications is erectile dysfunction. Is the patient at risk? Other endocrine causes like hyperpituitarism or hyperprolactinemia. Is there evidence of cardiovascular disease? Is the patient hypertensive to start with? Are they a vasculopath, known to have a previous history of TIAs, CVAs, or peripheral vascular disease? Remember that we can view erectile dysfunction as a barometer of cardiovascular health, and that's an important note to remember. Other causes would include neurological causes like underlying CVA or demyelination, trauma. So have they recently had their prostate removed and damaged the nerves? These are important things to consider when you're looking at organic causes of erectile dysfunction. And just as a side note, I think it's also important to remember that there's an interplay between the underlying pathological condition like hypertension as a cause of erectile dysfunction and also the tablets that we give them to treat it. Depression, we know, can cause erectile dysfunction or lack of libido, and yet also the tablets we give to treat them can cause it. So we have to bear both in mind, and it can often be a difficult line to call, but that's just something I'd certainly recommend. Now, let's assume that we don't think that our patient has these organic causes or gives a history suggestive of these organic causes, but and it points towards a non-organic or psychogenic cause. I still would recommend that you do a series of blood tests, and at the very least examine the patient, do a blood pressure, check their fasting glucose, their lipids, gonadotropins, including testosterone, sex hormone binding globulin, and testosterone. I think that would be really important. And if all this is normal, again, with the list that we've also mentioned, we're quite happy that there's a non-organic cause, and that in itself as a reassuring tool or as a reassurance tool would be quite reassuring to the patient. So, as well as trying the usual things that we know about, like phosphodiesterase inhibitors and other aspects, psychosexual counselling would be really important in the latter group. And look at your own local protocols and pathways to see if this is something that the NHS can provide. I would certainly welcome your experiences and how you feel your services are equipped to deal with this issue, and welcome your feedback on GP Bootcamp. Many thanks.